So it's my pleasure to introduce Dr. Emma Tsai, who is visiting us from CUNY Graduate School of Public Health and Health Policy, where she's an assistant professor in the Department of Community Health and Social Sciences, and has several colleagues and collaborators in the room, I believe. She obtained her MPH and PhD at the Johns Hopkins Bloomberg School of Public Health, and I will allow Dr. Tsai to give more of her research background and interests in the talk. So please join me in welcoming Dr. Tsai.
Thank you. Good morning, everyone. Thanks so much for coming. It's really a pleasure here and to get to talk with you today. The title of my talk is Bringing the Voices of New York City's Low-Wage Workers into Public Health Research and Practice. And I'm going to be talking about I'm going to try to talk about two different projects in the next 45 minutes or so. Close here. As Minal said, I'm going to start with my background and some of my research goals to give you a sense of where I come from and some context for this talk. And then I will talk about a project that my team and I did with institutional food workers. And I'll explain to you what I mean by that. And then I'll talk about a second project that we've been working on with home health aides. And I'll wrap up with next steps and hopefully some time for questions. So, since public health researchers take such a wide array of approaches, I thought it might be helpful to place myself a little bit. So, as Minal said, my training was in public health at the master's and doctoral level, but I've had a focus on anthropological and qualitative methods throughout that training, and you'll see that in the projects that I present today. I've also had an enduring interest in the intersections of work and health for low-income populations. And in public health, this means that I'm in conversation with, even though I sit in a community health and social science department, I'm in conversation with people in occupational health. I'm collaborating with people in occupational health. And I'm very interested in their emerging concept of well-being, which is starting to be theorized for workers. And also in practice, this means that I'm really interested in how we protect vulnerable populations and vulnerable workers from work-related harms, as well as how we potentially change their jobs or alter their jobs to help them protect and promote health and well-being. Both my public health training and my anthropological training have really impressed on me the importance of context and the need to examine problems at multiple levels with multiple stakeholders in order to understand them well. And also, stemming a little more from the anthropological training, I'm committed to the incorporation of narrative research methods, including storytelling and participatory methods. And you'll see that a little bit in today's talk. Incorporating these where feasible and appropriate, with the goal of bringing grounded perspectives and worker voice into our understanding of problems, program design, and policy making. So in public health, we love to relationships with big knots of boxes and arrows. So I've tried to give you an overarching sense of my research goals with this slide. So you will note that low-wage workers, health and well-being is at the center of what I work on. And I should also say that in public health and in occupational health specifically, historically the focus has been on toxic exposures and work-related injury. But in recent decades, there's been more and more of a move toward looking at how we prevent and manage chronic illness at work, and also what the work influences on mental health and well-being are. And so my work is very much positioned in the mental health, chronic illness space. And let's see. So you'll see that I'm also very interested in the green boxes that are on this slide. So the social and health policies and health promotion programs that shape the work that these kinds of workers do, as well as their health and well-being. And then finally, in some kinds of work, there is a client involved, a care recipient, someone who's receiving services from the worker. So in some cases, the projects that I've worked on have included the perspectives of and impacts on those people as well. And both of the projects I'll talk about today have a little bit of touch on that a little bit. Oh, and just the last thing about this slide, those arrows kind of going out to the side up to the green boxes are meant to suggest that the experiences of low-wage workers are that we really feel strongly that these should be informing both the programs that are designed and also the policies that influence workers and their health. So I'll dive right into my research on institutional food workers and their implementation of publicly funded food service. As background, let me say a little bit about what publicly funded food service is and why public health cares about it. So many publicly funded or subsidized organizations provide food. Sometimes this is in the course of fulfilling their other functions. Sometimes they provide food as a public service. And so these kinds of organizations can include everything that you see on this slide, everything from schools to childcare centers, senior centers, even universities and colleges, jails. And so increasingly, public health and others have viewed these as, they've started to call these institutional food settings. And these places have been a site of interest because they're seen as opportunities to provide nutritionally sound meals to large groups of people on a repeated basis with the hope of promoting health and well-being. So as a result, we have federal, state, and city nutritional standards and guidelines for publicly funded food. And the greatest attention in this space has been paid to schools and school food, which probably many people have heard about and read about and interacted with perhaps through children. And of course that makes sense that the emphasis has been on school food because of the scope and reach of those institutions. But there are also a lot of other kinds of organizations that provide publicly funded food. And so the focus in the project that I'll talk about today is on those non-school institutions, a selection of them. So it makes sense then that institutional food workers are the people who are preparing food in these settings. And interestingly to us, this is a workforce that is virtually invisible in the public health literature, with some minor exceptions around school food. But this is interesting to us because these workers are very demographically similar to food service workers more broadly. They experience a lot of the similar sort of physical potential risks and harms and stressors that food service workers in other environments do. And also we think they're interesting because they have the potential to play a role in the health of the people they're serving. And that's particularly the case in smaller, less centralized settings that do their own purchasing and food preparation. And that is the focus of the project that we worked on. So what was this project? We were invited in by a program that was being implemented mostly in Upper Manhattan and the Bronx, across a variety of different types of institutional food settings. So mostly childcare centers, but some after-school programs, senior centers, and shelter. And they had been rolling out for a couple of years this Healthy Menus program, which had a few different components. So the first was they had completely revamped their food service, or at least the menus that they serve to their clients, according to these 6 principles, which may look familiar to people as sort of related to the work that Michael Pollan has done and his exhortation from a number of years ago now to eat plants, not too much, or eat food, not too much, mostly plants. And so there was that kind of revamping of the menu system that would be served at these sites. But then also there was the need to comply with federal nutrition guidelines so that these meals could be reimbursed, and those guidelines are the Child and Adult Care Food Program guidelines. And then the third piece of this, which we were really interested in, was that they did some training with environments. Before the program, mostly cooks had been reheating food, using processed foods, and so they were suddenly being asked to prepare foods from scratch. And so they did 4 trainings a year in kitchen skills, knife skills, learning the menus, learning the 6 principles, figuring out how to get this to fit with the CACFP guidance. And so we were interested in how all of this was playing out, as was the program. So from an evaluation perspective, they had asked us to look at a couple of things. They wanted to know how are cooks implementing these programs, because they're at sites all over the city. Typically they're working in teams of 2. The sites are pretty small, and the cooks have a lot of agency and make a lot of decisions about what happens, and what hampers them in carrying the program out as planned. And then alongside this, we had a couple of additional questions, which were, how do cooks translate nutritional guidelines and knowledge into their knowledge that they acquire through the work that they're doing, through the trainings, into what ends up on the plate in these settings? Because of course we know that what's on the menus is not exactly what is going onto the plate and being eaten. And then finally, we were interested in what effects this program has on cooks themselves. Do they take up these nutritional guidelines in their own lives and start to implement them? And this is a very similar framework to what I showed you before, but here the food workers' health and well-being is at the center. We have the federal nutrition policies that shape the work that workers are doing, as well as this Healthy Menus program. And here we are interested in eaters' health and well-being to the extent that we're interested in how the work that these food workers are doing shapes those experiences of nutrition. And just to kind of demonstrate the multifaceted nature of this work and multidisciplinary nature of the work, we published a commentary piece discussing the potential of institutional food workers in public health in the American Journal of Public Health. Our paper on how workers, how their work shapes eaters' health and well-being was in Public Health Nutrition. And then the effects of workers was published in Food Culture and Society. And I have a slide at the end with references that lists all of these papers, and I'm happy to share them with people. So our methods. So we took a somewhat anthropological approach in this project on a very small scale, in the sense that we wanted to triangulate different perspectives and use different methods to understand what was going on. So we did semi-structured interviews with cooks in a variety of settings, in English and Spanish. We did semi-structured interviews with 9 of their supervisors to understand the environments in which the program was being rolled out. And we did structured and unstructured observations in kitchens during work hours and during training sessions to get a sense of what are cooks learning, how are they taking it up. The structured observations were very much part of the evaluation plan and were something that the program wanted to look at really closely, which was, this is what's on the menu, take a look at what's on the plate, how do these things compare? So what's the program fidelity, essentially? And this is who was in our study on the cook side. So you can see they had a really wide range of ages, vast majority female, majority foreign born, and the majority of the cooks we recruited were in early childhood settings, which is reflective of where the program had been rolled out. We also had a number of people in the study from senior centers, and then a smattering of other sites. So one question, actually before I get to this, one question that the Healthy Menus program leaders really wanted us to be able to answer was, whether cooks were adhering to these menus or not, as the research questions would suggest. So this is a major part of what we evaluated, and generally cooks were trying very hard to adhere to the menus and were taking that role very seriously. There were some structural barriers to doing this related to purchasing and getting the kinds of ingredients that they needed and maintaining those ingredients. But what we were really interested in were the times when cooks chose not to serve what was on the menu, or when they chose to alter it, using their own sort of agency in decision making. So we might ask what motivated cooks to change what was on the menu. And what we heard across the board was that many of the cooks felt that some of these healthy recipes needed to be changed to ensure that clients or eaters in their environment would consume them. And so these are some of the changes that they made. They weren't hugely radical changes in terms of nutrition, but they were notable in that they're this kind of skilled, detailed work that cooks were doing across all of these different kinds of sites. So they were taking out some ingredients. Sometimes they were serving them on the side, or they were telling us that they were serving them on the side. They were disguising ingredients that clients might not like. And generally, the goal seemed to be to make the dishes seem more pleasing and familiar to eaters when possible. So one cook in our study said from an after-school program, I go home and I'll try a recipe and see how it tastes. Because sometimes the way they want us to cook it is just like, okay, these kids are not going to eat this. And so, I mean, this kind of thing was very notable to us because these are really low-paid jobs with very little in the way of benefits, and yet the level of commitment that many of the cooks demonstrated to the work and doing the work really well was notable to us. This is someone who's going home and after hours trying out these recipes. So we might also ask, why do cooks care about whether clients are eating? We could certainly, I mean, I think my imagining of a cafeteria cook prior to doing this project was as someone who didn't care very much. You know, their job is to prepare the food and put it out, and if people eat it, great, and if not, whatever. But these are cooks who really, really cared about whether people in their settings were eating the food. And there were two things that were really driving this. One of the factors was a concern that clients were not getting enough to eat, not just in that environment, but more broadly. So one of our cooks said, it's not worth it to serve kids something they're not going to eat because those kids are here until 6 in the afternoon. This is a childcare setting, some of them. So these children will be there without eating. I will send them a cookie or cheese or whatever there is to replace their meal, or I will make a vegetable soup for them. I find a way to make them eat something that they like. And then another factor driving this in the data that we collected was really a sense of pride in being able to understand what clients would eat and being able to make modifications that would help them to eat it and to enjoy it. So we think that this says something about cooks and their experiential awareness of food insecurity in their environments. So the Food and Agricultural Organization of the United Nations defines food security in this very aspirational way as something that exists when all people at all times have physical and economic access to sufficient, safe, and nutritious food to meet their dietary needs and food preferences. So just a few points before I go back to this definition. So despite a generalized concern about overeating in the United States, in institutional settings, especially those catering to young children and to seniors, the problem of not eating enough is actually more common, and certainly was more common in these cooks' experiences. And in settings where large proportions of clients may be food insecure, and where cooks come from often the same background as clients and have their own experiences of food insecurity, they really understand that for food to be good and for it to be healthy, it has to be eaten, which seems very obvious, but this was something that was just very present throughout our data. And so in public health, we really emphasize the safe and aspects of this definition, the dietary needs part of this definition. But what we argue cooks are doing is sort of correcting for who's in front of them and what their preferences are and what they will actually eat. And really speaking to the sufficient part of this and the food preference part of this definition. So in addressing these multiple dimensions of food, they're helping the organizations that they work with in some ways to see and begin to address food insecurity and tailoring these population level nutritional guidelines to help that happen. So we think this is very skilled work that they're doing. The idea of balancing multiple goals accords with a notion in the literature of nourishing care, which is a concept put forth by Anne-Marie Mall, who's a theorist of care. And she writes that nourishing care involves delivering multiple goods whose relations to one another are highly complex and which thus require attentive experimentation by carers. And so we argue that this is what was going on in a lot of these sites, that there was some very attentive experimentation around what people would eat, what they wouldn't eat, and how to alter the guidelines to meet that. So Cook's practices indicate an awareness that there are multiple dimensions of good food that must be balanced, addressing hunger, pleasure, relationships between eaters, between cooks and eaters, as well as economics. We heard a lot about food waste and Cook's investment in reducing food waste. So we also note that neither job descriptions nor labor contracts for those workers currently acknowledge these skills that appear to potentially support food security among clients of institutional food providers. And so we've had conversations with this program about trying to build in and better recognize in their training programs this idea of attentive experimentation and sort of feeding back what cooks learn on the ground at their sites into how the program operates. So finally, I'll just briefly mention some of our findings around the effects of these programs on cooks. So they did gain access through the trainings to new forms of knowledge and skills related to nutrition. And they often tried to deploy these new forms of knowledge and skills to improve the health of family members, of friends. They knew a lot of people who were struggling with diet-related disease, obesity and overweight, diabetes. And so there was a real sense of empowerment to try to intervene into that using food and nutrition. As one of the cooks said, we are the doctors of food, very proudly. She felt that in her community, she was taking on that role. But on the other hand, there was an understanding that we learned about through interviews and more informal conversations, an understanding on the part of program leaders that it takes time to implement these kinds of programs well and effectively and with fidelity and across many sites and with so many cooks and different purchasing systems that they didn't expect it to go 100% well. But on the other hand, this is a huge change for cooks who are marginalized populations who have mostly worked in pretty insecure jobs. And it created a lot of new anxieties for them around the new skills and labor that were demanded as part of their job, how they were being evaluated in terms of these new menus, and how they could appropriately communicate about falling short without risking their jobs. So this, I think, complicates this idea of build attentive experimentation into the training program. It sounds great, but this is the backdrop for that is important to recognize. So I will move on now to talking about the project that I wanted to present on home health aides, which is some more recent work that my group has been engaged in. So for a group like you, I'm sure that this group of workers does not require as much explanation as institutional food workers, who almost no one knows about. But for those of you who are less familiar with this workforce, it's important to know that home health aides provide support to people in their homes. They usually provide help with the activities of daily living. They engage in other tasks as well. And they can provide either shorter term or longer term care in the home. So it might be a stretch of days up to many years. What's also important to know from an occupational health and population health perspective is that this is a workforce that is growing very, very rapidly as our population ages. Those of you who are doing clinical work, do you have patients who are home care workers? Yeah. And so nationally, we know that this is a workforce that's overwhelmingly female, disproportionately women of color and immigrants, low wages, few benefits. They have unpredictable and often part-time schedules, even when they would prefer to have full-time schedules frequently. There's little opportunity for advancement and a relatively high incidence of job-related illness and injury. Some of that stemming from dangers in the home, but some of that stemming from the many stresses of this job as well. So why were we interested in studying how patient death affects home health aides in particular, especially given that they're under so many different types of stress? Why focus on this type of stress in particular? So first we saw hints of the importance of this stressor in some earlier work that a colleague of mine had done looking at how home health aides influence quality of care. It just sort of came up in a lot of the qualitative work we were doing really repeatedly as a major event in the lives of aides. So we became interested in investigating it further. And when we looked at the literature, we saw some strong suggestions that patient death potentially has multiple impacts in the lives of aides that we were interested in. So on the one hand, Katrine Berner and her colleagues had done some work showing with home care workers here in New York City that they experience emotional grief symptoms that are similar to those of family members, maybe not at the same level, but many similar symptoms. And then also there was this kind of incidental mention in some work by Delta Montaner out in California that losing a patient may mean losing a job temporarily, which is just logically true, but I think something that's very different for home health aides as compared with other healthcare workers who experience the death of patients. So our goals then became to do an in-depth qualitative study about this experience specifically for home health aides, and to learn from them what their coping strategies are and what kinds of supports they would want to have in place in order to support them as they navigate these inevitable events that are part of the work that they do. So we saw this as a preliminary step towards developing some ideas for interventions and to test and other kinds of recommendations. So again, a similar framework, home health aides, health and well-being at the center, and we are sort of noting and interested in the way that federal healthcare policies are influencing their work, health and well-being, as well as their employer agencies and the policies and practices that those employers are using, and also interested in aid training and assistance programs. And then finally, this isn't as much a focus in this work, but my colleague Emily Franzosa has done some work in this area on how the work of home health aides influence patients and families' health and well-being. So we've published in some qualitative research journals, and then this link, Emily's work has been published in the Gerontologist. So our methods for this study were that we conducted focus groups. We recruited home health aides from their union training fund. So these were all unionized aides, meaning that in terms of pay and benefits, they were doing a little bit better than those national numbers that I showed a moment ago, or sort of alluded to. They were all English speaking because of resource limitations. Most were from the Caribbean, some from West Africa, some from Latin America. They had worked in home care for a range of years and also had a wide age range. And so after conducting the focus groups and realizing what we had recognized before, that the work that home health aides do is very isolated work. And yet we heard a lot in the focus groups about the importance of social support in dealing with these events. And so we became interested in what home health aides might say to one another about these experiences and what we might learn about their coping techniques and the kinds of supports that they might want if they were just talking to each other and not part of a research interview that was led by a researcher. I thought this might give us a different perspective on people's experiences. So we invited everyone who had been in the focus groups to come train with us for a day in interviewing skills and to interview another home health aide. 7 people said yes, they came in and interviewed each other in interviews that were 30 to 45 minutes long. And then we did another focus group about their interviewing experiences, although they continued to talk a lot about the experience of patient death. So I wanted to play a clip from the peer interviews. So we asked permission when we set up the peer interviews after they were completed. We asked aides permission, sort of reflecting on what they had talked about, to see if they were willing to let us use the audio out in the world, both to raise awareness about this issue as a stressor and to potentially develop trainings for aides or others that might help to sort of improve people's ability to deal with these events. And everybody said yes, and they also said that they wanted their names associated with the audio. So that is so I'm about to play you 2 1-minute clips from a 40-minute interview. This is a home health aide who, she's reflecting on the loss of a client who she had worked with for 8 years. So it was a pretty long-term relationship, but nowhere near the longest that we've heard about in our study. And I think it gives you a sense of one version of the experience of this. So I'll play a minute and then I'll introduce the next minute.
That our last conversation, we talked, she was in high spirit, and so I left. So in the morning, I was on my way to work, just came out of my street and my cell phone rang. It was her daughter on the phone. I said, I'm good, I'm going to get lost. She said, well, don't hurry. She said, because mom passed last night. And that was like a target. It hit me so hard. I said, okay, well, that was my case for the day. I didn't have any other case. And I couldn't just walk away. So I told her daughter, I said, I'm coming.
So she goes to the patient's house and engages with the family. She describes actually sort of doing the hair and makeup and the sort of typical things that she would do with the patient to prepare her for people to come by in the last hours that she was at home. And then she describes what it was like leaving the patient's house. And I'm curious to hear from you after we listen to this next minute clip, just what kinds of things stand out to you about what you hear in Linda's story.
And leaving that home that day, oh my God, it was heartbreaking. I turned, and when I said goodbye to the family members, I couldn't look at them. I couldn't look at them because the tears were flowing. They were flowing uncontrollably. I couldn't control it. And for days and for months, and even I remember, even now, I still remember her. I always refer to her as the best patient I had.
So this is a long-term and pretty positive relationship between an aide and And what's interesting is we heard a lot of stories like this one, but we also heard from aides who had patients who they didn't like. It seemed like even if people worked with someone for an extended period of time, even if they didn't like that person, the loss was still a loss. There was a kind of intimacy associated with this relationship and the routines of the day and being in someone's home and knowing their family and knowing their friends that made that a loss even when there was the absence of this kind of liking. But I'm curious about what people heard in this or what you noted.
She sort of felt like them, but she's not really family. There's a little bit of a barrier there.
Yeah. Yeah, I mean, I think you especially hear that in the second clip, this idea of having to hide her tears from the family and the kind of emotional labor that's involved in that. We heard a lot from aides about not wanting to take away from the grief of the family, and also that as a professional, they shouldn't show these emotions, even though they were often hit really hard with them.
In most cases, like, she spent more time with the patient than any family member, so it's this weird, like, dichotomy. It's like she wants to grieve, but feels like she can't fully.
Yeah, and there were certainly situations that we heard about where families included the aide as a member of the family, invited them to the funeral, but many more situations where the aide's work was not considered the huge contribution that it may have been, or there was even maybe what you're alluding to, some kind of sense of competition between the family and the aide. So let me turn now to our findings now that we have this as just kind of a backdrop. So in terms of the effects of patient death that we heard about from aides, our findings certainly echoed those initial findings that were in the literature. In looking at this closely, we were able to document not only the various aspects of grief, but also that there was significant distress in a lot of cases, not in every case, but in a lot of cases, that there could be self-blame, especially because these are workers who don't get a lot of training, and so they worry that they didn't know enough to do the right thing in that situation. There was a lot of anxiety about future patient deaths stemming from this. And then the stress that aides would experience in these cases often manifested as self-reported sleeplessness, hair loss, and a number of people reporting perceived increased blood pressure in these periods. And then we also heard a lot about the financial effects of this for aides. So, and really about the intricacies of case reassignment. So if they were not able to be assigned to a new case in a timely fashion, they would lose pay, and sometimes if they lost a lot of hours, they would lose their healthcare benefits. But these were intersecting risks. So often there were situations in which an aide was hit really hard emotionally by the loss of a patient, and then their coordinator or their scheduler would reach out to them and say, I have a really good case for you. And they would say, I just can't take it. But that would create a problem for the coordinator, for the scheduler, such that they might not reach out as readily again with another case. So it was this kind of feedback loop of the longer it took to get back on track, the harder it was to get a good case, a good, more full-time kind of case, which is what most people wanted. And then kind of on the other side, we documented some experiences that aides had around personal growth and professional recognition that came up around these events. So appreciation from patients, their families, some members of the care team, and occasionally the supervisor or would kind of recognize what they were going through or what they had done or learned or the care they had provided. In terms of their coping strategies, we heard about the ways that they coped and the ways that they tried to cope. So this is everything kind of mixed in together. And so they talked a lot about drawing on personal strength, some of this from religion, a lot from a sense of professionalism. They also talked about emotional protection via boundary setting with patients and families. And then finally connecting with members of their social networks who they drew on not only for emotional support, but in a number of cases for financial support when they didn't have work. So one of our aides said, you definitely need somebody to talk to, someone who you can confide in, you can't do this alone. So what I think is really important to note is that they had varying levels of success in actually using these coping strategies, and that all of these strategies are sort of complicated by the nature of the work, most notably the boundary setting strategy. So a lot of the aides said that they thought that they should have better emotional boundaries with patients and their families, but that the relationships that they developed with patients, they felt were very important, sort of a foundation of the care that they were able to provide, and that even doing the support for activities of daily living that are the kind of basic part of their job would, in some cases, would not be possible if they didn't have these kinds of relationships. So even though people talked about wanting to do that or trying to do that, they really were not able to. And we also noted, and aides noted to us, that strategies involving their employer agencies were really absent, and that they talked in a number of cases about how a lack of recognition from the agency about these types of events and this stressor could compound their grief pretty significantly. So it makes sense then that in terms of the supports that they desired, a lot of these were in the domain of the employers, in the domain of the union potentially. And they generally fell into emotional and financial supports, but there's some crossover here. A lot of them felt that a call or a check-in from that coordinator or scheduler person who they had the most contact with at the agency would be very meaningful, just to recognize the potential loss that they had experienced. Some people wanted time off, some people wanted time on to distract them from what they were feeling. And as I said before, we learned a lot about the scheduling and how tricky this is, that some people wanted to go back to a full-time case right away. Other people didn't want to have another close relationship, and so they wanted temporary cases, but the hours were often not enough. So I will conclude very quickly and overly briefly, by saying that what we ended up arguing was that workers appear to experience what Kenneth Dova, who's a psychologist, calls disenfranchised grief. So grief that is not openly acknowledged, socially validated, or publicly observed. And that it makes the emotional side of this a lot harder, as well as the kind of financial instrumental scheduling side of it. So to stabilize this workforce and protect its health, more formal systems of emotional and financial support for workers need to be developed and strengthened. And we think that the schedulers and coordinators may be a really important site of intervention, as the people who have the most contact with aides, and yet who in a lot of cases are not very supportive. Facilitated in part by my colleague, Dr. Recre, we're currently conducting research with employer agencies on ways of improving policies and practice at the employer level. So far what we've learned is that many agencies recognize this as an issue, really want to do something about it at the highest levels of leadership, but feel really hemmed in by their payment model in terms of finding ways to do that consistently. So next steps on the home health aid work, we are hoping to develop and test some policy and programmatic interventions that would support workers better through these periods, and we want to continue to incorporate and generate worker stories. We think these are really helpful in illuminating what this looks like for people. And then more generally, for my work as I move forward, I'm hoping to continue to sharpen my focus on immigrant women workers in New York City and their health. That group has been very involved in these last two projects, but especially given the current policy environment, I want to continue to focus on that and continue to focus on and strengthen my efforts around non-standard forms of work, which are part-time work, this kind of agency-based, insecure work of varying kinds, because it is proliferating in the way that it is, and because qualitative and ethnographic research is really important in that space, since we don't understand how those kinds of jobs work very well and what sorts of impacts they have on people. So I will end there. These are some acknowledgements for collaborators and participants and funders. This is part of our team for the Home Care Workers Project. And these are some of the references that I mentioned. But I'm very happy to take questions in the last minutes. I know we have to end at 9:30 sharp.
I'm actually interested because you said these are actually unionized workers. So if they don't have the benefits, and really those that might not have the union will probably have a lot less than nothing. Do they get like more? I'm sure they have some benefits if they're in the union membership.
Yeah, so they do have access to some mental health benefits that are relevant, but a lot of people didn't have good awareness of those. And they have access to paid time off, but it's interesting. So we heard from workers, we want paid time off so that we can take this time if we need to. So we can take 3 days before we get reassigned to the next case. So across the board, we heard workers don't have paid time off. And then we spoke with folks at the union and at the agencies, and they said, no, workers do have paid time off. But it gets paid at most agencies, it gets paid out as a lump sum at the end of the year. And so workers see it as like a small cash bonus on the very low salaries that they're paid. They don't think of it as paid time off that could be used for something like this. And so what they really wanted was dedicated paid time off for bereavement in this situation, which is a predictable part of the work, which I think is very reasonable. Alex, what do you ask?
Yeah, so I'm just thinking, listening to what you were saying about the role and the experiences of the caregivers, that perhaps that provides an entree to expanding the research that's done on caregivers, or the informal caregivers, where the bulk of the literature lies.
Yes.
Perhaps ought to be now expanded out to these paid caregivers, given that they are experiencing a lot of what's described in the informal caregiver literature, sort of emotional burden, psychological burden, probably some health impacts as well. And given the long-standing relationships that they often have with with their clients, that seem quite reasonable. And yet it's more complicated because it's a paid relationship.
Yeah, absolutely. I mean, I think that's the case that I, Jenny, and others are trying to make, that we have learned a lot about family caregivers from the large literature that's out there, but that these roles they have some overlap with that, but that they're unique as well, and that we need to understand the complexities of, and also the kinds of interactions between family and caregivers. It's a very, very interesting and very complicated set of relationships.
How did you choose the qualitative methods for each of these projects?
That's a great question. Yeah, I wasn't sure how much to go into that and how much I had time for that. So generally, I think of focus groups as being a good tool to use when you're trying to understand kind of the social norms around a topic, because that's what you're going to hear from people who are bouncing ideas off of each other. And in the case of the Home Health Aids Project, we really wanted to hear about people's experiences in a little more depth. So focus groups weren't the ideal method, but when we worked with the union, they said it's going to be really hard for you to interview home health aides, and what we would prefer to facilitate are focus groups. I mean, we would prefer to help you set up focus groups. And so initially it sort of gave me pause. But then at the same time, we knew that these were isolated workers and that being together to talk about this might be really interesting and helpful, and that workers who had less experience with patient death, putting them in a focus group with people who had more experience might help to create a better understanding for us than just an interview with someone who didn't have that much experience with patient death or who only had one experience. So the focus groups ended up working well, even though initially I thought that was not the best way to go about it. And then with the cooks, we really wanted to focus on, we wanted to understand their personal contexts for doing the work that they were doing and their path into institutional food. So we really needed to use interviews. Focus groups wouldn't have been appropriate. And then we needed to triangulate with observation because just hearing from them about what they were doing wouldn't tell us everything about what they were doing.
Because I feel like with the grief, we talk a lot about like these long-standing relationships and relationships that are like family. Was there also talk about grief and sort of what it looks like when they're shorter relationships? Because I know for myself professionally, like some of the deaths that are most striking for me were like on my inpatient rotations where I sort of showed up, was there for this crazy thing, somebody died, and then was like on to the next one. And sort of it's a different version, but I just wanted to see if it both those pieces.
Yeah, absolutely. We were actually very surprised to hear from workers. We thought that we had a sense from the focus groups that the longer the relationship, regardless of whether it was a positive or negative relationship, the more emotionally difficult things were. But then in the peer interviews, one of the things that a number of people said to each other was occasionally people had been assigned to a handful of hospice cases, but didn't focus in that area or specialize in that area and had no training. And they said that even being on a hospice case for like 2 or 3 weeks could hit you as hard as something that, where you had a real relationship with someone. So we didn't have deep enough data in that area to really get into how that grief experience was different from the others. But certainly we noted your experience was echoed in our data. Catherine.
Were you able to examine any kind of gender differences in the process?
For home health aides and the patient gender.
Yeah.
We did not detect any. Certainly aides talked about both male and female patients. I guess in reflecting on the data, we did hear a little bit more about female patients, but there were some experience. Yeah, it's a good question, actually. You're making me want to look back at the data a little more closely.
We do see a lot of differences just in families.
Yeah.
And that whole process.
Right.
And I know your sample is obviously skewed towards more women.
Yes.
But I think, there are male paid caregivers.
Yeah.
Well.
Oh, you're talking about the paid caregivers. I thought you were. Yeah. It's a good question. You're definitely making me want to look into our data again.
I've never had any male home attendant in any of my patients. The only attendants I see is from the home male. I've never seen any male.
Yeah.
With any of my patients. I don't know.
Yeah, I mean, I
don't want to bias when you think of caregivers, you think of more female.
Yeah. Well, and I've spent a lot of time now in the union home health aide training programs and continuing education, and I would say 95% of people in those programs, they see 15 to 20,000 home health aides in New York City a year, and 95% of them are women.
A lot of male patients want male aides, so I've had that
There's a lot of
experience.
situations where physically
Yeah.
It makes them feel more, but also like men who feel more comfortable not having what they see as like a pretty young, whatever, like they want that.
All right, well, thank
Thank
you.
you.